Good morning, Dr. Phil here. Today we will be discussing on bispectral index BIS. Introduction to awareness with recall. Memory and awareness. Memory can be classified as implicit unconscious memory and explicit conscious memory. Conscious recollection of events, including intraoperative events, would fall under the category of explicit memory. Awareness with recall, AWR, during general anesthesia is referred to as anesthetic awareness. Although patients may speak of remembering certain things under GA, recall of specific intraoperative events is the key to the concept of anesthetic awareness. In 2006, ASA Practice Advisory for Intraoperative Awareness excludes dreaming as anesthetic awareness. Regarding to intraoperative awareness with recall, this refers to intraoperative consciousness in cases in which unconsciousness is expected, with post-op explicit recall of operative events. This should be distinguished from intraoperative awareness without recall. Higher anesthetic doses are usually required to induce unconsciousness compared to inducing amnesia. Incidence of AWR, about 1 in 19,000 when large cohorts such as NAP5 are examined. Implications of AAGA. Intraoperative awareness with recall, while rare, is distressing and is associated with psychological sequelae. It is closely associated with patient dissatisfaction. It can result in anxiety, helplessness, sleep disturbances, and 33 to 70% develop post-traumatic stress disorder. The primary contributing factor for intraoperative awareness is inadequate anesthetic dosing. This can occur when the anesthesia provider does not adequately dose the anesthetic. Patients have elevated anesthetic requirements, patients too ill to tolerate adequate levels of anesthesia, or anesthetic delivery system malfunction. Risk factors for AWR includes at-risk populations such as in obstetric surgery, urgent or emergency surgery, cardiothoracic surgery, female gender, younger adult age, obesity, and prior awareness under anesthesia. Other risk factors include light levels of anesthesia, use of muscle relaxants, malfunction of anesthetic administration such as machine failure, IV anesthetic pump failure, extravasation of IV medication, medication error, etc. Unrecognized increased anesthetic requirements, such as in patients with chronic substance abuse, is a risk factor for AWR. How should a patient with suspected AWR be approached? The patient may volunteer information regarding AWR or seem angry or sad during perioperative interview without a clear reason. This should prompt a more structured inquiry using open-ended questions, such as what is the last thing you remember during your previous anesthetic? When there is concern for AWR, the modified BIS questionnaire is useful to characterize the event. It consists of 5 questions. What is the first thing you remember after waking up? Do you remember anything between going to sleep and waking up? Did you dream during your procedure? Were your dreams disturbing to you? And what was the worst thing about your procedure? This questionnaire has been shown to be more sensitive in detecting intraoperative awareness with recall compared to other methods. A recap on sensitivity, specificity, PPV and NPV. Sensitivity is the proportion of people with a condition who are correctly identified by a screening test as indeed having that condition. Tests with high sensitivity are good for ruling out disease, hence the mnemonic SN out SNOUT. Increased sensitivity permits people to be confidently regarded as not having a condition if their screening test yields a negative result. Regarding specificity, it refers to the proportion of people without a condition who are correctly identified by a screening test as indeed not having the condition. Tests with high specificity are good for ruling in disease, hence the mnemonic SPIN SPIN. Increased specificity permits people to be confidently regarded as having a condition if their diagnostic test yields a positive result. PPV is the probability that people with a positive screening result indeed do have the condition of interest. NPV is the probability that people with a negative screening result indeed do not have the condition of interest. Detailed documentation is indicated once a case of AWR has been identified. listen to and acknowledge the patient's recollections, offer consolation, explain the likely circumstances surrounding the situation, such as presence of cardiovascular instability or trauma, reassurance to the patient, offer psychological support, notify surgeons, nursing staff, and hospital legal counsel. The ASA Task Force on Intraoperative Awareness notes that not all patients need to be notified regarding the risk of AWR, but for high-risk patients, informed consent should include discussing the increased risk of AWR. Are there strategies to decrease the incidence of AWR? Strategies include pre-medication with amnesic drugs such as benzodiazepines, appropriate doses of induction agents, supplemented with amnesic medications, especially if airway management is difficult or prolonged. Avoid muscle relaxants when possible. Supplement nitrous narcotic anesthetics with volatile anesthetics. Maintain proper functioning of anesthesia machines. Ensure function of IV delivery equipment. And consideration of neurophysiological monitoring such as BIS. Basics of EEG. EEG monitoring involves placement of multiple electrodes on a patient's scalp to measure the electrical activity of the brain. This electrical activity is portrayed by waveforms with varying frequencies and amplitudes. It is then deconstructed via Fourier transformation into the commonly recognized waveforms with distinctive frequency ranges. This includes delta, theta, alpha, and beta waves. Delta waves, less than 4 Hz, occurs during deep sleep, during GA, or organic brain disease. It originates in the cerebral cortex independent of lower brain centers. Hence, these waves occur even when the cerebral cortex is disconnected or severed from the reticular activating formation. Theta waves with a frequency of 4 to 8 Hz. These arise from the parietal and temporal area. It occurs most commonly in the first stage of sleep, as well as during general anesthesia and deep meditation. Alpha waves, 8 to 12 Hz, arise from synchronous activity in the parietal occipital cortex. The waves are typical of a normal awake state, with eyes closed, i.e. rhythm of inattention. These waves result from thalamocortical activity and are abolished when the cerebral cortex is disconnected from the thalamus. Beta waves, 14 to 80 Hz. These are low voltage, less than 50 volts, asynchronous waves present in the frontal area. Intact thalamocortical projections and functional ascending reticular input to the thalamus are necessary for these waves to be recorded. These waves replace alpha waves in the presence of visual stimulation and increased mental activity. Regarding processed EEG, quantitative analysis are commonly employed to guide EEG interpretation. These calculations can be grouped into time domain and frequency domain analysis. Regarding time domain analysis, this describes how the pattern of waveform changes over time. The burst suppression ratio is calculated as the proportion of time that EEG activity is suppressed during a given time interval. Burst suppression is more common in the setting of hypoxia, brain trauma, and while administering high doses of anesthetic medication. Frequency domain analysis describes the EEG signal as a function of frequency. Power spectral density is a graphical representation of the Fourier transformation of raw EEG, with x-axis being frequency of each component wave, y-axis is power, i.e. amplitude squared. Frequency of each component wave is plotted on the x-axis, and its corresponding power plotted on the y-axis. Bispectral analysis is a higher order frequency domain analysis. It quantifies the relationship between those component waveforms generated from Fourier transformation. This is done by comparing the amplitude and phase angles of different waveforms at varying frequencies. Bispectral analysis incorporates power and phase information of component waveforms at two frequencies, f1 and f2, and a modulation component, f1 plus 2. The bispectral value is defined as the product of the spectral values at f1, f2, and f1 plus 2. This value is large when the component waveforms are well aligned and have large amplitudes at the given frequencies f1 and f2. The spectral value is small when the waveforms are not aligned or having small amplitudes at the given frequencies. BIS monitoring. There are a number of brain function monitors that uses proprietary algorithms to process raw EEG data and provide anesthesiologists with a value intended to represent the depth of anesthesia in patients. BIS is the most widely used. In addition to the BIS monitor, other monitors include SetLine, Narcotrend, and M-Entropy. Regarding SetLine, it can be combined with cerebral oximetry for monitoring of regional oximetry. PSI in the range of 25 to 50 indicates an optimal hypnotic state for general anesthesia. For further information, kindly refer to the SetLine website attached here. The BIS algorithm interprets raw EEG data gathered from forehead electrodes and provides anesthesiologists with a dimensionless BIS value ranging from 0 to 100. This proprietary complex algorithm is derived empirically and iteratively using an EEG database and behavioral scales among subjects exposed to different anesthetic protocols. After removing noise and artifacts from a variety of sources, EMG, from facial muscular activities and peripheral nerve stimulators and electrocautery, it then combines the following parameters to generate a single BIS value: burst suppression ratio, quasi-suppression, beta power, and synchronization of low-frequency activity, sync fast-slow. Regarding burst suppression ratio, type of domain is time, significance, period of fully suppressed EEG. Regarding quasi-suppression, type of domain is time, significance, it is the period of nearly suppressed EEG. Beta power type of domain is frequency, significance is degree of high-frequency activation. Sync fast-slow type of domain is frequency, bispectral, significance, low-frequency synchronization. A BIS value of 0 represents persistently suppressed EEG activity and 100 indicates fully awake state. Target range of between 40 and 60 is the proposed range in which patients have a lower risk of experiencing intraoperative awareness with recall during GA. Depending on the type of BIS monitor, additional values on the monitor includes EMG, which is a measurement of muscle activity. The BIS value becomes less reliable as the amount of muscle activity increases. Unit of measurement is Hertz. SEF 95, or 95th percentile of spectral edge frequency, is the frequency below which 95% of the total EEG power lies. Power is amplitude squared. This value decreases with increasing levels of general anesthetics or opiates. Unit of measurement is Hertz. Next is TP, or total power. This is a summation of power of the various component waves. Unit of measurement is Hertz. Next is signal quality index, SQI. This refers to the quality of the EEG signal, 100% representing perfect signal quality, 0% refers to poor signal quality. Unit of measurement, percentage. Next is the suppression ratio, or SR. This is the proportion of a 63-second time period during which EEG activity was suppressed, i.e. isoelectric. This value is inversely proportional to the BIS value. Unit of measurement is percentage. Next is ST, suppression time, which displays the cumulative time spent in suppressed state. The DSA graph. The density spectral array is a graphic display of the power spectrum distribution over time, where the amplitudes of the power spectrum are represented by varying colors. Blue represents the lowest powers, red represents the highest powers. The DSA graph is displayed along with additional values such as DSA plus BIS and DSA plus amplitude. In this graph, the white line represents SEF, spectral edge frequency, which denotes the highest significant frequency in EEG spectrum. 95% of power is below that line. MF, median frequency, which refers to the purple line in this graph, whereby 50% of power is below that line and 50% power is above that line. The EEG bands delta, theta, alpha, and beta, and their corresponding labels appear on the right side of the DSA graph. The bottom part of this graph shows a yellow line, which refers to the BIS value at the respective time point. The BIS graph can be replaced with an amplitude graph, which shows the amplitude at the respective time point, whereby amplitude is the maximum absolute voltage of EEG waveform conveyed in decibels. With advancements in BIS monitoring, 4-channel BIS monitor, along with the BIS bilateral sensor, allows detection of bilateral hemispheric differences in the brain. The left and right hemisphere data may be orientated on the screen as on the left or right side, or upper or lower side. Factors that affect BIS reliability: erroneous placement or decreased adherence of EEG leads increases electrode impedance and falsely elevates BIS values. Facial EMG activity and certain electrical devices such as electrical blade and pacemakers can introduce high-frequency signal artifacts, falsely elevating BIS values. The use of ketamine during anesthesia can lead to a more uniform distribution of higher frequencies and desynchronization in EEG, falsely elevating BIS values. Nitrous oxide can preserve alpha waves while suppressing low-frequency delta waves. Suppression of low-frequency delta waves increases BIS value falsely. Neuromuscular blockers can cause spuriously low BIS values. Predictive value of BIS as a monitor for awareness. Various studies have been conducted to assess the ability for BIS to reduce the risk of awareness during general anesthesia. The Be Aware study, which involved 2,503 patients, concluded that BIS monitoring reduces the risk of awareness in at-risk population. The Be Unaware study involved 2,000 patients, concluded that BIS monitoring does not reduce the risk of awareness. The Back Recall study, which involved 6,041 patients, concluded that BIS monitoring does not reduce the risk of awareness. The Michigan Awareness Control Study, which involved 21,601 patients, concluded that BIS monitoring does not reduce the risk of awareness even among the general surgical population. The study by Zhang et al. In 2011 involved 5,228 patients undergoing TIVA, concluded that BIS monitoring reduced the incidence of awareness during total intravenous anesthesia. A study by Punjasang Wadong Cochrane Review combined data from 8 different clinical trials, found that when compared with monitoring for clinical signs, BIS monitoring reduced the risk of awareness. However, when compared with an ETAG-based protocol, BIS monitoring failed to reduce the risk of awareness. BIS monitoring during total intravenous anesthesia. During TIVA cases, anesthesia providers are not able to rely on end-tidal anesthetic gas measurements to monitor for intraoperative awareness. While it is possible to titrate doses of IV anesthetics using target-controlled infusions, this technology is not routinely used worldwide, and there are significant inter-individual variations in IV anesthetic dosing required for loss of consciousness. This may have contributed to increased rate of awareness during anesthetic cases using TIVA, which has been shown in NAP5. Similarly, in China, the rates of intraoperative awareness during general anesthesia among the general population is 0.4%, with TIVA being a risk factor for intraoperative awareness. Due to our inability to monitor plasma levels of IV hypnotic agents with the TIVA technique, EEG-guided methods such as BIS monitoring may be uniquely well suited to measure anesthetic depth during TIVA. An RCT conducted in China studied the utility of BIS as a monitor for awareness during TIVA cases, found that there was a 78% decrease in incidence of awareness among the BIS monitored group compared to the control group. While reassuring, these findings have yet to be replicated in additional RCTs. This algorithm shows a practical approach to use BIS during maintenance phase of TIVA. First, ask whether the BIS value is between 40 and 60. If yes, assess whether the signal is reliable. If yes, continue with current anesthetic regimen. If the signal is not reliable, assess and address reasons. Assess whether the leads are misplaced and whether there is electrical interference, etc. If the BIS value is not between 40 and 60, assess whether the BIS value is more than 60. If the BIS value is more than 60, there might be concurrent change in surgical stimulus and/or clinical signs that may suggest need to increase the anesthetic dose. High BIS values may be due to false elevation in the setting of mechanical interference or recent administration of anesthetic agents that increase BIS values, such as ketamine. If BIS is less than 40, assess whether there is concurrent change in surgical stimulus and/or clinical signs that may suggest a need to decrease anesthetic dose. BIS may be falsely low due to the administration of muscle relaxants. Consider acute decreases in blood pressure, temperature, and blood glucose in the absence of acute changes in surgical stimulus or anesthetic dose, and treat accordingly to stabilize the patient. Non-awareness clinical applications of BIS. BIS reduces anesthetic use by as much as 38%. BIS reduces the incidence of post-op complications and associated healthcare costs. BIS decreases the incidence of post-op delirium in elderly and at-risk patients. It improves patient satisfaction, patient outcomes, and quality of life, and accelerates wake-up times, recovery time, and discharges from PACU. BIS reduces the incidence of post-op nausea vomiting. BIS monitoring may be valuable in identifying high-risk patients. In a study by Sessler et al., which involved 24,000 non-cardiac surgery patients, found that the occurrence of low MAP, less than 75 mmHg, in concurrence with low MAC values, less than 0.80, and BIS values of less than 45, was associated with a significantly higher risk of 30-day mortality. Applications of BIS in the ICU. BIS helps in titrating dose of sedation to avoid oversedation or undersedation. Oversedation may lead to patient unable to participate in healthcare, longer time on mechanical ventilation, longer length of stay in ICU, increased hospital costs and risk of delirium. Undersedation may lead to anxiety and agitation, risk of recall or awareness of unpleasant events, threat to patient safety and staff safety. BIS provides objective assessment of sedation level, for example during mechanical ventilation, barbiturate coma, bedside procedures, and neuromuscular blockade. This is especially useful when sedative scales can't be used effectively. Objective assessment of sedation levels help in managing complex pain, agitation, delirium, and improves emergence and recovery times and optimize patient outcomes. Bedside nurses found that BIS monitoring to be easy to use, easy to interpret, and is a helpful tool for communicating the patient's comfort level to their family. BIS monitor can help prevent post-op issues such as delirium, PTSD, sleep disruption, cognitive impairment, and nausea and vomiting. BIS monitoring may help guide sedation practices during shivering management for patients undergoing targeted temperature management, and in patients with ARDS with ongoing neuromuscular blockade with or without proning. These are my references. Thank you.